I'm Sean Fitzwater. I'm with Pediatric Infectious Diseases at Kaiser. It's exciting to see a whole bunch of pediatricians today. Before I get into this, I have a lot of data. I'm going to burn through slides really quickly. I'm hoping that a lot of this kind of brings up conversations for us pediatricians to have this weekend. But background here, there's a high variability in treating and testing for cocci among pediatrics. A lot of the management within our system and outside of it is done by primary pediatricians who really have no guidance on this. And then specifically for this project, it was catalyzed because the pediatricians I work with in Kern County said, hey, we want specific information, we want guidance. So common management threads that we commonly see among pediatricians is they have trouble interpreting serology, and there's a very large level of fear among providers and the pediatricians and the families regarding cocci, which kind of pushes their management to be very conservative. So our goals were basically to describe the variability in treatment, to kind of describe the outcomes in these patients, examine the utility of monitoring, specifically serology, and to put together guidance for our pediatricians to use kind of like out in the field. So a bit about Kaiser Southern California. At any one time, there's about 900,000 pediatric members within our system, and we range from Kern County all the way down south to San Diego. It's vertically integrated, and the care is given exclusively through KP, so we always get our kids back when they go away, and usually they're there for years, if not decades. So we have good follow-up. So what did we do? Well, what we did was basically identify kids based on ICD-10 codes and based on if they had had a cocci screen based on the ELISA. The laboratory testing was considered positive. We considered them a case if they had a positive lab test and they had active symptoms consistent with cocci. It was only kids, and we did it across a couple years between 2015 to 2021. We excluded anybody who had a primary infection outside of this window because a lot of kids are getting monitoring done for quite a while, but we only looked at the active ones who were diagnosed with active cocci within this window. So the laboratory criteria was you either had a positive cocci antibodies by EIE, EIA, ID, or CF, or culture confirmation or histopathology consistent with cocci. And the clinical criteria is basically active cocci, symptoms consistent with active cocci, and no alternative diagnosis. Disseminated cocci was considered if there's evidence of an active disease outside of the lungs via one of those testing methods. And if there's a doubt, the benefit was given to the care provider if they decided it was cocci. Okay, we confirmed the cases based on chart reviews. We've got all their symptoms, their serology results, the treatments, the outcomes, and the complications, and followed them up for however long they're within the Kaiser system. And what did we find? Well, we ended up finding over 3,000 kids who were either positive, had been screened for cocci or had a diagnosis of cocci. Most of these fell out because their tests were not positive, but a good number fell out because they had no symptoms. There's a lot of asymptomatic testing done. We found 209 active cocci cases, and 199 of these were basically non-disseminated, relatively mild cases. We found 10 disseminated cases. This is just kind of breakdown of it. The interesting thing here is that erythema nodosum was very common, and it was even without pulmonary involvement. And disseminated cases were really a mixed bag of cases. Just to say it out front, there's not very many disseminated cases, so it's hard to make a lot of kind of like points based on dissemination here. So really, we're going to focus a lot on the non-disseminated cases, which is most of what the outpatient peds folks are dealing with. Looking at their symptoms and imaging at presentation, none of this is going to surprise people, but it's the common things you see in everybody: fever, cough, rash, lots of erythema nodosum, and many had no respiratory symptoms. One interesting thing I noted is that erythema nodosum was one of the primary triggers for a cocci workup for these outpatient peds doctors. And imaging, about 20% had perfectly normal chest imaging, and the rest mostly had focal consolidations, but there was a grab bag of other findings on chest x-ray as well. We can look at incidence because we have basically population-based data, and we saw a pretty wide variety across the region, which is going to be broken down kind of in this slide here, which makes a lot of sense when you think about it. We saw a really high incidence in the San Joaquin Valley up in Kern. We saw an intermediate incident kind of in this area where we have these large agricultural plains, San Fernando Valley, Antelope Valley, or the Oxnard Plain. And then for the rest of Southern California, kind of like the more urban areas south, we really had a very low incidence. And this data kind of matches up with the California data in general as well, but I think it's fun to look at. Looking at the demographics, not surprisingly, we see most of the disease in the older kids and in teenagers. It's pretty well split between genders. We'll get to race later on because we can break it down based on the incidence we see. And then most of these kids are going to be treated with antibiotics before they come in and finally get diagnosed with cocci. And most of them get diagnosed within a few weeks of symptoms, while some limp in after a month or so. And the primary way we're diagnosing cocci in kids is serology, which is not surprising. When we're looking at it by race, we're going to focus on Kern County because the racial breakdown of the population varies widely in Southern California depending on where you are, and cocci is where we have the highest incidence, so this is where we get the best data. And we saw some variability across different races. It's difficult because there's a lot of people who have unknown race in their charts, so it's hard to know which way those kids would have gone if we had known one way or the other. And it's really unfortunate not granular enough to really look at Filipino ancestry, which is always a particular concern, just because that's missing from our population data largely. Now, when we look at demographics and dissemination, we can get a little bit more information. Here, we're basically seeing, when we break it down by race, we're seeing that there's over a 7-fold higher risk of dissemination for African-American folks living in Kern County, maybe some slightly lower risk for white people. But again, we really can't say anything about Filipino or Asian cases because we didn't have any dissemination in the limited number of disseminated cases that we found. We're looking at symptoms and risk for dissemination. A hodgepodge of things really kind of stuck out. People with fever, cough, and rash of any type had a lower risk of having dissemination. More importantly, weight loss was the biggest thing that really jumps out as concern for dissemination, because there's a 30-fold risk if you had weight loss with an active cocci that you were going to end up having dissemination. So we had a lot of serological results because we did a lot of testing. We had over almost 500 IgG and IgM pairs among all these patients. Oftentimes these are repeated because it's just part of the panel they send. So as a byproduct, we have multiple repeat of IgG and IgM results. And CF, we have over 1,000 that we're looking at here. These were usually sent to determine, can we stop treatment or not? When we're looking at the serological results in terms of from when your first symptom was onset to when we found basically that kids look like they're having elevated or positive IgG and IgMs pretty darn quickly. Within a first week of life, most kids were IgM positive. Within 2 to 3 weeks, basically everyone was IgG and IgM positive. And then it kind of dropped off over time like that. You can see that IgM drops off a lot quicker, of course. And for CF, we're really not seeing that increase until after about a month or two. And then it's remaining persistently positive. But a lot of kids who had active disease never developed CF positivity. One question we always have is, well, what are we going to do with that CF when we get it? So here we're looking at the time from onset of symptoms to when the maximum CF was noted and the first CF decrease was noted. And what you can see is that it's usually about 1 to 2 months until we see a maximum CF. And I think interestingly and important for kind of our treatment decisions is we're not actually seeing a decrease until 4 to 6 months afterwards. And when we exclude the disseminated cases, when we exclude the severe cases like the kids with the nasty pneumonias who admitted with effusions, we see this exact same pattern. And it kind of brings up the question, if we're making diagnostic or treatment decisions based on CF, and we know they're not going to actually CF decrease until 4 to 6 months, how useful is that, especially in these mild cases? Other question is always like, well, what do we do with the serology that comes back first, the IgG and IgM, in terms of we know there's false negatives initially, and there could be false positives later on. We do have pretty good data here showing that what to expect in terms of the evolution of antibodies in kids. Specifically, after 28 days, we're just not seeing kids with IgM positive that are IgG negative. And similarly, under the first couple of weeks, we are not seeing kids who have IgG positive but IgM negative. And this can be helpful for us to determine if we actually need to be too concerned about cocci in these kids. Because again, the default for most pediatricians is if they're positive, treat them. For CF and dissemination, what we basically saw is that, yes, dissemination was more likely in the high titers, but by and large, most of the high titers were relatively mild, non-disseminated cases. When we kind of try to put this as a metric to see its sensitivity and specificity, basically no criteria in terms of how high the CF was, either initially or maximum, really had good sensitivity or specificity for disseminated disease. Looking at their treatment and outcomes, this graph makes me cringe because a lot of kids with very mild disease were treated for, years, because a lot of the pediatricians are treating them for a long time because they're under the assumption they need to treat till their serology is negative, and that oftentimes does not happen. The most common reasons we see that they decide to stop treatment can be just that the CF became negative or remained negative on follow-up testing. By and large, almost all of these kids were treated with fluconazole alone, although we did have a good number of kids who weren't treated at all and were observed for years. Looking at kind of management factors, I think the key thing here that I want to focus on is for our non-disseminated kids, we had 3 recurrences. These are patients who were treated, stopped treated, and they came back in with symptoms again, which equals about 2% of the treated patients in total. And we had 1 kid who failed observation off antifungals, which equals about 1.8% of all the untreated patients, which is surprisingly similar. For disseminated, we saw a lot more recurrence. We saw some treatment failure, although these were a little bit tougher to tease out just because how sick some of these kids were. We're looking at the timing of CF testing because, again, a lot of these kids had CF testing for years. The thing that stands out here is that, we had about 5+ CF tests per kids in this study, and about a quarter of them were sent after a year, even in the mild cases. When we're looking at how useful that CF testing was, we had 40 kids who had documented increases in CF titers after 180 days, and we looked at how it affected their care. If it was done just for lab monitoring, it really didn't change their management at all, except in some cases it led to inappropriately long treatment courses. If they came in with symptoms and that triggered a CF test, that was helpful. About half of them were discounted and thought to be false positives, but in about half of the cases, it did lead to prolonged appropriate care and in some cases diagnosis of recurrence. We're looking at the non-disseminated cases specifically. The maximum CF wasn't really an indication of the reactivation risk. A lot of the 2 of the 3 kids had pretty low CFs and reactivated later regardless. The kid who failed observation off antifungals, he didn't have an increase of CF. It was diagnosed based on symptoms. So it really kind of brings in the question of, for these relatively mild cases, what's the utility of this constant CF monitoring? For disseminated cases, harder because we did see recurrences and treatment failures. We did see patients who did get their CFs sent routinely, and the CFs increased before they had diagnosis of recurrence or treatment failure, but those weren't actually acted on until they had clinical indicators. So I guess my key points is that, most pediatric cases, unsurprisingly, are very mild, but there's a very high variability in treatments. And the treatments tend to be extremely conservative because every pediatric cocci case to a pediatrician is generally going to be thought to be pretty severe, even if we might not think of it as severe. So we kind of need better guidance for these pediatricians on the ground. Serology, we can use this to really interpret the risk of, a false positive or false negative based on their onset of symptoms. But really, this poor understanding of serology on the pediatric level for these pediatricians is leading a lot of these questionable decisions and these months to years of fluconazole treatment that otherwise probably shouldn't have been given. So honestly, serology probably should be more thoughtful and limited in these kind of patients. So again, observation for these non-disseminated cases is certainly reasonable for mild cases, and the utility of CF is questionable at best, and certainly something we should probably discuss more. For the non-disseminated cases, again, a lot of them are sicker. There's not enough cases to make any kind of good points here about that, but something we like to look at in the future. And because of this, we implemented some guidelines to help our outpatient pediatrics kind of manage it more appropriately. And then because now we have this data set, we're going to be looking at the next set of kids in a couple of years. So we look at the outcomes for kids now that we have this more rigorous, options and guidance for these pediatricians. One But that is it for me. I'd like to thank John over there for helping me analyze the data, and Kiara, my resident, who helped me pull all the data and
We don't have a lot of time. Let's go ahead, Royce.
Paul may have the same question. Where is your cocci serology done?
It depends on where they are. So if you're in Kern County, it's Kern. Everywhere else, it gets sent to the local lab where we do the EIAs, and then the CF all goes up to Davis. But the majority ends up getting done at Kern because the majority of testing is done in Kern.
Well, I just make the point that cocci serology is not cocci serology is not cocci serology. It matters enormously where it's done. Quest's CF titer is 2 tubes higher than ours.
Yeah, and I thought about looking at that and then decided it was too difficult.
All right, Paul.
Can't say enough good things about how important and how nice this presentation is. And you know, your study here. You commented about erythema nodosum, and certainly at UCLA, we've seen a wave in the last year of getting cases where the pediatricians put people on fluconazole when they get an ELISA positive symptom test and they have E. nodosum. But back in '39, C.E. Smith and Dixon and others did a study on 24 kids and showed us they all did well. E. nodosum isn't perfect. How are you, as a predictor of completely benign future, despite your having cocci, do you have thoughts about how to work? Have you already thought through how you're going to talk about E. nodosum as a way to get people or get pediatricians to not routinely be putting people on fluconazole? How are you working that into your thinking?
One comment is that the next study I want to do is just, it's easy to pull Kaiser data, and we'll be looking at every kid who has a diagnosis of E. nodosum to see how much cocci of it is actually cocci. So that'll be fun. I'm looking for a resident to do that. But part of our regional guidelines is specifically that E. nodosum is generally thought as relatively benign, as a way to reassure them. And at this point, everyone calls me for cocci. And usually when I'm talking through their cases, I can use that as a way to reassure the families and the pediatricians that this mild case probably doesn't need to be started on treatment and just needs clinical follow-up in a couple of weeks.
Awesome. Mine is a follow-up question. So I am not a pediatrician. Looking at those epidemiology data, your proportion with rash was 60% and your proportion with fatigue was 25%, flip-flopped in adults. So the 60% that had rash, do you think it's selection bias? Do you think pediatric patients are more likely to have rash and or E. nodosum? And along with the prior question, since E. nodosum is a good prognostic indicator, do you think that kids just tend to do a lot better than adults?
I mean, kids certainly do a lot better than adults.
Yeah.
I think we're blessed in that they just generally do great. And I say that it's hard to say if, what I would say is that kids are very rashy people. So if they're being brought in for a rash, it's usually pretty dramatic that they're ignoring the normal rashes. So that says to me is that if they're being brought in for rash, it probably means it's a dramatic rash, which probably means it's there for cocci. And it probably means that if you're not getting the same complaint in adults, it means there's a lot more rash in kids.
All right, Don.
Your study started with ICD-10 codes or serology, and I was curious if you could care to comment on the usage of ICD-10 codes for larger epidemiology studies and what your detail work might imply for people that only have access to ICD-10 codes.
And Don, let me pile on to the field since we had another question. How reliably the used?
So positive serology is easy. So one of the main reasons to do the serological aspect is because there was quite a few kids who were clearly had cocci, that they looked at them and it's like, oh, you've had symptoms for 3 weeks. Your IgG is positive. Your IgM is negative. Your IgG and IgM are positive. Your CF is negative. You don't have cocci. They sent them home. They had hives and erythema nodosum, clear cocci, chest X-ray positive. So we saw a lot of kids who were not diagnosed with cocci who clearly had it based on serology that were included. ICD-10 codes, we saw a few that didn't have cocci, but by and large, it did match up pretty well to the final diagnosis. It's the missed cases we found who just were positive on screening, but were kind of discounted because they misinterpreted the tests, basically.
All right, one more question.
Yeah, hi. Thank you for the presentation. I was just wondering about the, have you noticed any typical or atypical presentation between different age groups as far as adolescents, toddlers, or infants, how they usually present?
So that I can't say offhand. You know, in general, though, teenagers just are a bit sicker. And my assumption is that they're acting more like adults than they are little kids. Again, probably the littler kids are also getting infections as well, but they're just not being seen. But incidence-wise, the highest incidence is teens, probably not because they're getting exposed more, because they're getting more infections, just because they just do worse. So similar to adults would be my assumption.
Okay, thanks, John. And our final talk is Pearls and Pitfalls of Intrathecal Amphotericin B Therapy for Refractory Coccidioidal Meningitis in Children from Sanchi Malhotra, University of California, Los Angeles, Kern Medical Center, Stanford, and Keck School of Medicine.